correlation between corneal epithelium, tear film, and meibomian gland in dry eye patients using OCT. This research was purely for academic purpose. It did not carry any commercial values or financial interests. Starting from the introduction, dry eye is a multifactorial disease of the ocular surface that do cause the homeostasis of the tear film, and the patient do feel the irritation, redness, watery eye, and the photophobia. Here is a brief literature in which noteworthy US study said that dry eye impacted 1.6 in which noteworthy US study said that dry eye impacted 1.68 million people in US, out of which 73.6 were females and 26.4 were males. In another study, epithelium of the cornea supports the tear film and protects the underlying components. And one more study, Jung and et al. Said that lower lid typically have 20 to 30 glands, that is the meibomian gland, and the upper lid do have 25 to 40 meibomian glands. And if there is compromised meibomian gland, that do call the meibomian gland dystrophies, and it do cause the illness of the eye. The objective of my study was to correlate the corneal epithelium thickness, tear film height, and the meibomian gland. The study design was correlation study. It was done at Mayo Hospital, Lahore. The sample size was 70 eyes. Sampling technique was non-probability convenient sampling, and the formula used were Pearson and Spearman. The sample was collected from both genders of age more than 18 years. All were cooperative patients and diagnosed cases of dry eye. The patients with any other ocular opacities or any other pathology were excluded. This is the picture that how the dry eye cases were diagnosed using the slit lamp and fluorescein staining. For diagnosing the dry eye or to take the imaging, in OCT we do check the lid margins, that is the tear film height, meibomian gland imaging, and the corneal epithelial thickness. This is the first scan in which we have taken the scan of the cornea. And here it is this layer, this is the corneal epithelium, and in OCT we can caliper and measure the thickness of the cornea. That was the second scan in which we measured the tear film height. Here you can see this is the tear film height, and we can measure it on OCT. This was a typical case of dry eye. Here you can see you cannot see the tear over here. That was the third scan in which we imaged the meibomian gland. And this is the standard picture, like according to the international study. Here we can grade the meibomian gland according to the tortuousness of the glands or the disappearance of the gland. After collecting the data, that were the results of my research. Here it is the correlation between corneal epithelium and tear film. That was minus 0.128. It's a negative correlation that we can also say that there was no correlation between these two parameters. The correlation between corneal epithelium and meibomian gland was 0.099. That was a weak correlation. And the correlation between tear film and meibomian gland was 0.056. That was a moderate correlation. This is the graphical presentation. Here you can see that how the tear film and corneal epithelium were compromised, and these bubbles are showing the grading of the meibomian gland. Here is a conclusion that the first two parameters were having negative correlation, second two parameters were having weak correlation, and last two parameters were having no correlation. The recommendation that if we increase the sample size, or if we do the same study in rural and urban areas, or between the screen users and non-screen users, can bring the different results. Thank you so much.
Thank you, Ms. Sarish Shahid. Our next speaker is Mutahir Shah, who will present the topic excessive near work and pseudomyopia, comparative cross-sectional study among children at age 4 to 16 years. Our next speaker is Ms. Sabah Ghalib, who will present the topic impact of digital device usage on myopic progression in young patients.
Assalamu alaikum. I am Sabah Ghalib, currently working as senior lecturer in Rawalpindi Medical University, Rawalpindi, lecturer for optometry and orthoptics. The topic that I am going to present is impact of digital device usage on the myopic progression in young patients. So starting from the introduction, as all of us are familiar with the myopia, is a condition in which the parallel rays of light coming from infinity are focused in front of retina, with accommodation being at rest. And according to the predictions from World Health Organization, about 50% of the population may be myopic by 2050. So the screen time, extended usage of the digital devices can also lead to the increased risk of myopia up to 30%. And if this increase is associated with computer usage, then this risk can be increased to 80% almost. And the collection of the vision and the related health issues resulting from the digital device usage can also be termed as computer vision syndrome. These were my objectives. The logic is based on the predication that a new recent environmental factor is included in our study, that was the digital media. The emphasis has been given to the minimizing the risk factors in various eyes to maintain preserve the eye health and prevent myopia in the younger populations. Now coming to methodology, descriptive cross-sectional hospital-based study was conducted at our department, Holy Family Hospital, Rawalpindi, from May 2023 to January 2024. Study population was myopic patients coming to IOPD of Holy Family Hospital. 80 patients were included in our study. Through the non-probability conjective sampling technique was used. The inclusion criteria was the patients with a myopia who have the regular device usage of almost 5 to 8 hours and kept at the follow-up period of minimum time was 6 months to track the changes in the myopic progression. And the patients were included in my study, and the patients who wear contact lenses or who have undergone the refractive surgery procedures were excluded from the study, and who were lost to follow-up. The patients with the conditions like amblyopia, strabismus were also excluded from the study. These were my data collection tools. After the Institution Review Board, the Ethical Institution Review Board of Rawalpindi Medical University has gave its approval to this study. Informed and verbal consents were obtained from the patients, and visual acuity of all the patient was measured using Snellen chart. Pinhole was also used to check any improvement in the visual acuity. Slit lamp examination and ophthalmoscopy are also performed where required to rule out any other ocular pathology. Digital device information, including the frequency, duration, and type of devices, was taken on a self-structured performer. Now coming to the results, the major number of the male patients were observed in our study. 43 were males and 37 for females. Now coming to age-wise distribution, the maximum number of individuals were observed in the period 11 to 15 years of age was 46, and 5 to 10 years of age was 24. According to screen time, the maximum individuals had the screen time of 7 to 8 hours, and minimum individuals, 21%, had more than 8 hours of the screen usage. Now, Myopic progression, when we observe after the interval of the 6 months, 76% of the individuals showed about 1% increase in their myopic refractive error, and 24% showed no such significant progression. The type of device, the type of screen that the individual used was 58% were the individuals were using laptop or smartphones, and 12% were using tablets, 30% were using laptop computers. 82% of the individuals showed symptoms of asthenopia, eye strain, headache, blurred vision, and 18% of the individuals showed no significant symptoms. In this contingency table, we can see that out of total 43 males, 34 showed the myopic progression, and out of 37 total females, 27 showed the myopic progression. Now, in type of screen, the 46 out of 46 smartphone users, 43 showed myopic progression. Out of 24 laptop users, 20 showed myopic progression, and out of 10 tablet users, 8 showed myopic progression. The major limitation that we faced in our study was this study is conducted in the Asian population. For the findings to be accurate, the study must be conducted in the diversity of populations, and outdoor activities were not captured in our study. And further studies should incorporate the outdoor light exposure levels that a person should experience or undergoes. Other factors such as contrast, ambient lighting can also be observed in the study. So, coming to the conclusion, smart device screen time also increases the risk of myopia in the younger population. And the parents, the young individuals or the individuals who use screen should be encouraged to look at a distance of 20 feet if they worked for the 20 minutes at the screen for the 20 seconds to reduce the asthenopia. And the parents should set an example to engage their kids in the indoor activities or spending time outdoors. Indoor activities should be like in the form of non-digital media like course or the games. These are the references. Thank you.
Thank you, Ms. Sabah Ghalib. Okay, our next speaker is Dr. Mutahir Shah.
Mutahir Shah. I am currently doing my PhD in optometry and working as a senior optometrist in the Department of Ophthalmology of KRL Hospital, Islamabad. Today, the topic of my talk is relationship of prolonged near work and pseudomyopia in school-age children. What a pseudomyopia means: myopia is a condition in which parallel rays of light coming from infinity are focused in front of the retina, while your accommodation is relaxed. While in a case of pseudomyopia, it's a fast presentation and accommodation is not fully relaxed, and the patient looks like a myopic, or symptoms looks like myopia. It is often associated with excessive near work and prolonged screen time. If we technically define pseudomyopia, a condition in which spherical equivalent refractive error of less than minus 0.5 diopter prior to cycloplegia and greater than or equal to minus 0.5 diopter following the cycloplegic refraction is technically defined as a pseudomyopic condition. Why it is important to address the pseudomyopia in children? Because it is essential to prevent myopia incidence. It enhances the academic performance of the children. It will promote the long-term vision protection and eye health. It optimizes the vision comfort and quality of life of the children. It will educate the parents about the healthy visual habits of their children. So the study was comparative cross-sectional study conducted in the Department of Ophthalmology from August to November 2023 with judgmental sampling technique. A total of 51 samples were included, both male and female. Ethical approval was granted by the Hospital Ethical Review Board. A total of 51 patients having age of 11.6 with a standard deviation of 3.3 years and a range of 4 to 16. If you look, 36% of the population were females and 64% were male. If we look at the bar chart, the presentation, so the excessive screen time was around, the mean average time was around 5.93 hours, while the outdoor activities was even less than 40 minutes in a day. It's a mean pre and post refractive difference. Why we go for a cycloplegic refraction in a patient? Because the patients were having a myopic refractive error. However, their visual acuity was not corresponding with the refractive status of the patient eye. So we go for a cycloplegic refraction in the patient, and you will be surprised that the pre-cycloplegic refractive error was around minus 2.98 diopter. However, after the cycloplegic refraction, the refraction goes to a hyperopic shift of plus 0.54. So the difference between the pre and the post refractive status was around minus 3.5 diopter. That's quite a large number. However, the visual acuity was in the pre-cycloplegic state, it was 0.2 logmar, 0.23 logmar. After cycloplegia at PMT, it was around 0.04 logmar. We applied descriptive statistics, we applied regression analysis, but due to time constraint, I just only included the correlation analysis of our study with the magnitude of pseudomyopia. If we look at the daily near work, it is highly statistically significant. The greater you expend on the screen time, the greater will be the refractive error or the pseudomyopic magnitude. What we found from the study, recently studies shows that pseudomyopia itself is an independent risk factor for developing myopia. So if we identify the pseudomyopia in early age, we can prevent the incidence of myopia. It offers insight into myopia development in hyperopic children, because hyperopic children use their accommodation for distance vision. While they are using their vision for near, they use extra amount of accommodation that leads to pseudomyopia in prolonged work. It emphasizes on importance of cycloplegic refraction in children. It is especially crucial for those with hyperopia or poor visual acuity. It aids accurate diagnostic management of pseudomyopia. It urges the limitation of excessive near work, especially with digital devices. It emphasizes importance in light of increased screen time among children. The study assesses early intervention to prevent long-term visual impairments by identifying pseudomyopia and consequences in children. So what are the recommendations from our study? Mandatory cycloplegic refraction for every child. If the child is myopic, hypermetropic, or even the child is astigmatic, go for a cycloplegic refraction. Regular breaks while using gadgets for entertaining or reading purposes. At 20-20-20 rules, look after every 20 minutes at a 20 feet distance to relax your accommodation for 20 seconds. Outdoor activities and sunlight exposure, it plays a vital role in preventing the incidence of myopia. And the use of blue filters it's still debatable among the researchers, but it is effective in patients using their screens. Thank you very much for your time.
Thank you, Dr. Mutahir Shah. Our next speaker is Dr. Asadullah, who will be presenting evaluation of quality of life in patients with different types of cataract pre and post surgery. Cataract.
Bismillahirrahmanirrahim. The topic of my presentation is evaluation of quality of life in patients with different types of cataracts pre and post surgery. These are the contents of my presentation. Introduction. A cataract is a clouding of the crystalline lens in the eye. It is a common condition after the age of 40. 8,000 per million per year surgeries are performed in India. Cataracts can be classified based on their location within the lens, with the three most common types being nuclear, cortical, and posterior subcapsular cataracts. Cataract progression varies depending on the type of cataract and other factors such as general health and environmental factors. These are different types of cataract. The first picture shows nuclear cataract, and the second one is cortical, and third one is posterior subcapsular cataracts. Nuclear cataract tend to progress more slowly, while posterior subcapsular cataract progress more rapidly than cortical and nuclear cataracts. General health conditions such as hypertension and diabetes have also been linked to the development of cataracts. Other studies have shown an association between obesity, hyperlipidemia, and cataracts, particularly posterior subcapsular cataracts. Depending on the location of the opacity, cataracts can affect vision differently, causing different symptoms in each type. The treatment outcomes are important and relevant to each patient, and the criteria for a successful outcome can vary depending on the patient needs, lifestyle, and medical condition. After cataract removal, people may be able to perform everyday tasks more easily and with greater independence. including activities such as driving, reading, and watching TV. Studies have shown that mental health, physical function, and quality of life can be enhanced when visual function is restored through cataract surgery. However, there is a lack of information in the literature about outcome satisfaction for different types of cataracts. So the results of our study can serve as informative material for eye specialists to help prepare patients for what to expect after cataract surgery. Aims and objectives of my study were to evaluate how patient quality of life changes after cataract surgery and to find if there are differences between the responses of patients with nuclear, cortical, and posterior subcapsular cataracts. A study was conducted at Shifa Eye Care Clinic, Mardan, and the study duration was 5 months from October 2023 to February 2024. Patients, 210 patients, cataract patients were selected, and those were categorized into 3 groups based on their cataract types. Both genders, male and female, were included. Exclusion criteria of my study was all patients with AMD, diabetic retinopathy, glaucoma, and other ocular diseases were excluded out. Diagnostic tool used were slit lamp examination, tonometry, autorefractometry, and fundoscopy. Visual acuity measurement, monocular using Snellen chart, and best corrected visual acuity in distance and near, refraction recalculated in spherical equivalent. Surgical procedure done was phacoemulsification cataract surgery, 2-day delay between the surgery of both eyes, and monofocal Acrisop natural IUL implanted in all patients. Target refraction was 0 diopters, no complication reported after cataract surgery. For ethical consideration, patient informed and provided consent, study conducted with the Declaration of Helsinki. We have used the questionnaire, visual function questionnaire VF14 in the study. It is a brief questionnaire with 14 questions, covers daily life activities like reading, recognizing people, driving, etc. And scoring responses were graded from 0 to 4. Those who have no difficulty was graded as 4, and those with yes, with a little difficulty was scored as 3. Yes with a moderate difficulty was 2, and yes with most of the difficulty was 1. Yes and am unable to do any activity was graded as 0. And it was marked blank if the question is not applicable. Scores calculated as the summated responses divided by the number of valid responses multiplied by 25. Final score ranges between 0 and 100. 100 was able to do all applicable activities, and 0 was unable to do all applicable activities because of vision. Results categorized as severe 0 to 29, moderate 30 to 74, and mild 75 to 98, and no visual impairment 99 to 100. This is the visual function questionnaire having 14 questions. Patient filled out the visual function questionnaire at various periods. That was 1 hour before the first eye cataract surgery, and 2 weeks and 1 month after the second eye cataract removal surgery. Self-administered or with the help of an optometrist if the patient was illiterate. Analysis, in analysis, we have used ANOVA one-way test used for analysis, compared differences between before and after surgery, scores to each question and cataract group. This table summarizes the visual acuity and optical refraction data of cataract patient before and after surgery. It shows the best corrected visual acuity in far and distance, as well as optical correction measured in spherical equivalent. Before surgery, patient had varying levels of visual acuity, with some needing significant optical correction. After surgery, there was an improvement in the visual acuity for most patients, with a significant number achieving better visual acuity without the need for correction. The table highlights the positive impact of cataract surgery on improving visual acuity and reducing the need for optical correction in cataract patients. This table presents the questionnaire score of 10 cataract patients before and after cataract surgery. The score are categorized based on different questions related to daily life activities affected by cataract, such as reading small print, recognizing faces, and driving. Before surgery, patients reported significant problem with activities like reading small print and face recognition. After surgery, there was a significant improvement in most activities at the 2-week and 1-month follow-ups. The table provides a comprehensive overview of how cataract positively impacted patients' subjective quality of life in various daily activities. This figure shows patient questionnaire scores for reading small print before surgery at 2 weeks and 1 month after surgery. Demonstrate the cortical cataract patient and the worst feeling about the reading small print before surgery. After surgery, all groups showed improvement with no significant difference between them. This figure displays patient questionnaire scores for reading larger print before surgery at 2 weeks and 1 month after surgery. It indicates a subjective improvement at 2 weeks with no significant change compared to 1 month. Shows relatively highly subjective satisfaction with reading large print unaffected by cataract. This illustrates patient questionnaire scores for handwork activities before surgery and at 2 weeks and 1 month after surgery. It indicates significant improvement in performing handwork activities after surgery with no problem reported at follow-ups. And this is the last figure. They show patient questionnaire scores for driving during daylight and night time as well as watching television. Conclusion: 2 weeks post-surgery, patient shows significant improvement in quality of life, especially for near work. Cortical cataract patient exhibit the greatest improvement, followed by nuclear and posterior subcapsular cataracts. Before surgery, nuclear cataract patients were less affected in daily activities compared to cortical and posterior subcapsular cataract. And these are references of my presentation. Thank you.
Thank you, Dr. Asadullah. Our next speaker is Dr. Ikra Khalil, who will be presenting the topic role of vitamin D3 supplementation in the treatment of dry eye syndrome.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Ikra Khalil, working as Vice Principal at Munawwar Memorial Hospital and College of Optometry, Chakwal. And today I'm going to present my research on impact of vitamin D3 supplementation in non-Sjogren dry eye patients with low serum vitamin D level. Here are the contents of my presentation. Please have a look. As we already know that dry eye is a chronic multifactorial disease, and it is further divided into 2 types. Number 1 type is aqueous deficient dry eye, and number 2 is evaporative dry eye. Aqueous deficient dry eye is further divided into Sjogren and non-Sjogren dry eye. And we already know that vitamin D is a precursor which plays an important role in the metabolism of bones and immunomodulation. Vitamin D has anti-inflammatory and immunoregulation properties apart from its role in calcium metabolism. And unfortunately, in Pakistan, about 60 to 90% of women are suffering from vitamin D. Various ocular structures like cornea, sclera, ciliary body, and retina contain vitamin D receptors which play a vital role in physiology of the eye. All vitamin D supplementation affects the concentration of these metabolites in the anterior segment, thus promoting tear secretion, reducing ocular surface inflammation and tear film instability. The main objective of my study was to assess the impact of vitamin D3 supplementation in non-Sjogren dry eye patients with low serum vitamin D levels. Rationale of study: vitamin D deficiency has become a global issue affecting most of the population worldwide. Due to lack of awareness, people are more prone to develop dry eye disease. This increased disease burden and affect the quality of life. This study will help to find impact of all vitamin D3 supplementation on ocular parameters of dry eye. Here the literature review. Some earlier study conducted in 2015 reported that there was a significant association of low serum vitamin D levels with reduced tear breakup time and shimmer test findings. Another study conducted in 2017 also testified similar findings. They concluded that ocular signs and symptoms were measured by OSDI, tear breakup time, and shimmer test. Results confirm low vitamin D levels in dry eye syndrome than in controls. Here are the materials and method. This study was a randomized control trial, and this is the registration number because it was registered before. The study duration was from October 2021 to June 2022. Population study, the sample size was 108 patients, which was divided into 2 groups containing 54 subjects. Sampling technique, the proportive random sampling technique was used. Here is the consort diagram. All patients with the age group of 20 to 50 years of age who were suffering from non-Sjogren dry eye of both genders were included in the study, and the subjects who were suffering from any disease other than non-Sjogren dry eye disease were excluded from my study. Data collection procedure. After obtaining written informed consent, complete ocular examination, medical and family history was gathered through specially designed performer. Ocular examination was done on first day, day 15, day 30, day 60, and day 90. Best corrected visual acuity was also assessed. Here's the data collection procedure. Vitamin D level was assessed by COBS E14, Diagnostic Switzerland's. Ocular signs and symptoms were measured. Ocular signs were measured in the form of tear breakup time in seconds and shimmer test, while ocular symptoms were graded regarding OSD score and numerical pain rating scale. Deficiency of vitamin D level was considered when total level was less than 25 nanogram per milliliters. Patients having dry eye with low serum levels of vitamin D were randomly divided into two groups as follows. The group 1 received only tears 4 times a day, and group 2 received vitamin D3 supplementation 6,000 international units in addition to tears. Data collection instruments: slit lamp eye microscope, fluorescence strip, shimmer strips, numerical pain rating scale, and OSDI questionnaire. Statistical analysis were performed using Mann-Whitney U test and Friedman-ANOVA test. Ethical consideration was obtained from the Institutional Review Board of University of Faisalabad, as this was the requirement of a postgraduate degree. Of total 108 subjects, the mean age between group 1 and group 2 was almost similar. Here's the gender distribution of subjects. Please have a look. Here you can see the mean serum vitamin D level and the mean level are almost similar between two groups. Please have a look. This is a Friedman test which shows the relationship between vitamin D level and the symptoms and signs of dry eye. Here's a Mann-Whitney U test. And just to conclude, I'll say that the group receiving only tears and their only symptoms were improved, but the group which received tear and vitamin D, symptoms and signs, both were improved. Here's the discussion. Results are almost comparable with the earlier studies. And I want to conclude that oral vitamin D supplementation improved the ocular parameter of non-Sjogren dry eye disease by improving tear breakup time and shimmer test score. It also plays significant role in decreasing ocular symptoms of dry eye disease. It may serve as a new treatment option for non-Sjogren dry eye disease. Here the recommendation: prospective studies with larger duration and larger sample size should be conducted. Combined treatment strategies including both topical application of lubricant and systemic administration of vitamin D3 should be developed. Here are the references of my study. This is the self-structured performer. Please have a look. This is a consent form. Thank you.
Thank you, Ikra Khalil. Our next speaker is Maryam Sanaullah, who will be presenting on the topic clinical presentation of pterygium and associated risk factors.
Assalamu alaikum. My name is Maryam Sanaullah, and I am currently working as a course coordinator in Munawwar Memorial Hospital and College of Optometry, Chakwal. This is my presentation topic: clinical presentation of pterygium and associated risk factors. Here's the introduction. Pterygium is defined as radially oriented fibrovascular lesion that crosses the nasal or temporal limbus and can induce significant astigmatism, cosmetic concerns, and visual impairment because of the involvement of the visual axis. The prevalence of pterygium ranges from 0.7% to 31% in various studies around the world. Here are the risk factors of pterygium: sun exposure, low income and education, rural residence, age and male gender, and smoking. My objectives were to find out gender and age distribution of pterygium, frequency of risk factors associated with pterygium. Pterygium is a common ocular surface disorder which poses significant challenges to individuals' healthcare systems globally. Despite its prevalence, there remains a gap in understanding the link between its presentation and risk factors. By enabling people to address its modifiable risk factors, their vulnerability to this condition can be minimized. Educational interventions to modify these potential exposures may assist in preventing pterygium. Review of literature, Shah and fellows in 2016 conducted a study and concluded that simultaneous role of multiple risk factors, including sun exposure, hot climate, toxic material exposure, familial transmission, and dry eye in associated with pterygium. Similarly, Lim and fellows conducted a study in 2015 and concluded that male gender was associated with higher pterygium prevalence in younger age groups, while longer sun exposure increased pterygium prevalence in older age groups. Myopic eyes were found to have lower prevalence than hypermetropic eyes. Study design was cross-sectional hospital-based study. Place of study was Munawar Memorial Hospital, Chakwal. Duration approximately 3 months. Sample size was 60 and convenient sampling technique was used. Here is the inclusion and exclusion criteria. I included patients above age 30 years, both genders, and all 3 grades of pterygium. I excluded the patients below 30 years, recurrent pterygium, and pterygium retaining any cyst or malignancies like squamous cell carcinoma and malignant melanoma. Data collection instruments used were Snellen charts, slit lamp, autorefractometer, topical anesthetic agent, and fluorescein strips. I collected the data using self-structured proforma. Demographic data including age, gender, socioeconomic status, area of residence, rural or urban, occupation and educational history was collected. Visual acuity was taken by Snellen. Autorefractometer was used to check the K readings and refractive status. Subjective refraction was carried out, and the questions based with living environment, family history, smoking, working outdoors, UV exposure, residential area. These questions were filled using a proforma, self-structured proforma. The interior segment of the eye was examined using slit lamp. Tear breakup time was used to assess the severity of dry eye. Ethical consideration, verbal and informed, both ethical, verbal and written consent was taken from patients. Data was analyzed using SPSS version 26. Ordinary regression was used to find the association between variables, and Friedman's one-way ANOVA test was used as the data was not normally distributed. These are the socio-demographic factors. Age 31 to 40, these were 16.7%. 41 to 50 were 33%, 51 to 60, 20, and similarly 61 to 70, 25%, and above 70 were 5%. Gender, male were 40% and female was 60%. Rural area, with patients with rural area were 81.7 and urban with 18.3. Illiterate patients were 51.6 and literate were 48.3. Blepharitis present was 45%. UV exposure 1 to 5 hours was 61.7 and 6 to 10, 38.3. Patients with history of smoking were 18.3 and non-smokers were 81.7. Positive family history was 30% and negative was 70. Dry eye mild 8.3, moderate 83, and severe 8.3%. And similarly in the left eye, mild 5, moderate 76, and severe 18.3. Grades of pterygium, grade 1 35, grade 2 60%, and grade 3 was 3.3%. Visual acuity of right and left eye, you can have a look. Association between astigmatism and grade of pterygium. 13 patients with grade 1 had less than 1 diopter slender of astigmatism, and 9 patients with grade 1 had 1 to 2 diopter slender. Grade 2, 12 patients with grade 2 had 1 to 2 diopter slender, and grade 3 was minimum 2 patients only. So there were 4 to 6 diopter slender, and 1 was greater than 6 diopter slender. Odds ratio, you can have a look. Females, rural area, blepharitis, dry eye, and UV exposure had greater than 1. So it means it was a good risk factor for the pterygium, presentation of pterygium. Friedman test, p-value was less than 0.05%, which was statistically significant. Here's the comparison. I concluded that female gender was associated with higher pterygium prevalence, longer sun exposure, increased pterygium prevalence in all age groups. Other risk factors such as blepharitis, dry eye, and residential area also played a simultaneous role. Thank you.
Thank you, Mariam. So our next speaker is Dr. Mohammad Iqbal Javed, who will be presenting on the topic pattern, risk factors, and complications of diabetic retinopathy among Pakistan.
Assalamu alaikum. I am Iqbal Javed, working at Gulab Devi Teaching Hospital, Lahore. I will talk about patterns, risk factors, and complication of diabetic retinopathy. You know, diabetes mellitus type 2 is a metabolic disorder in which the body has higher sugar levels of prolonged period of time. And symptoms are frequent urination, excessive thirst or hunger, and weight changes. And causes are when there is inadequate production of insulin or insulin resistance. And treatment may include lifestyle changes such as diet control and medication or with insulin. Diabetic retinopathy is a public health issue, and diabetic mellitus and diabetic retinopathy are interlinked with each other. And here is the complication of diabetic retinopathy, and complications are cataract, glaucoma, diabetic retinopathy, visual impairment, and causes blindness. Here is the normal retina and a compromised retina. Methodology of the study was this was a cross-sectional study and of 6-month duration, and place of study was ophthalmology department, Gulab Devi Teaching Hospital. And age and gender, here are the 164, 44% were males, and 211, 56% were females, and total participants were 375. And duration, if we look here, this is duration 3 years to 5 years, 10 years, and 15 years, 20 years, and 20. And control of diabetes was very strictly and not strictly. And here we see that most of the participants were in the category of non-strictly. And very strictly were 4.2%, and strictly 34.4%, and not strictly 61.3%. And treatment taken, these we here see that the pills were taken in the larger group of the diabetic patients, and it was 65%. And here is some general and eye health advice. We here see that the 97 individual, that were 28% was taken health advice by the general physician, and only 13% was taken advice from the ophthalmologist. And visual impairment, that the mild visual impairment 14%, moderate 70%, and severe visual impairment in our study was 7%. And refractive error status, either hyperopia 27.20%, myopia 24.50%, and astigmatism was 26.60%. And if we see comorbid conditions, that the 65% were hypertensive, 41% were dyslipidemia, and 29% was obese, and 33% were ischemic heart disease. And complications, retinopathy, nephropathy, neuropathy, and stroke, and retinopathy was the higher present in the group. It was 46%. And diabetic retinopathy, that we here see that we concluded here in our study, it was 42.8%. Non-proliferative diabetic retinopathy, mild 40%, moderate 20%, and severe 9%. And proliferative were 15%. And macular edema was found 15%. And treatment here we provided to all the individuals in our study And this is the conclusion of our study. It is a big public health issue which compromise quality of life and lack of awareness about complications of diabetic retinopathy. And in the recommendations, awareness campaigns in community, initiate screening program, and effective referral chain protocol. And this is the message: nip the evil in the bud, awareness, DM screening, referral to the eye health facility. Thank you.
Thank you, sir. Okay, for our last speaker is Taiba Burhan, who will be presenting the topic and approach towards inclusive eye health.
Bismillahirrahmanirrahim. My name is Taiba Burhan and I am working as senior orthoptist in Mayo Hospital, Lahore. So the topic I'm going to present is on inclusive eye health. So we need to know about the inclusive eye health first of all. Inclusive eye health means ensuring eye care services accessible and welcoming to all sorts of marginalized people in the community, including people with sensory, physical, and intellectual impairments, transgenders, homeless, and those with some mental health condition. It also means proactively ensuring that people with long-term vision impairment access. So exactly the topic close to my heart as working in the community. It is an approach towards inclusive eye health, tailored screening to check the frequency of ocular problems in homeless community in Lahore. So we need to know that what is exactly is the prevalence of homelessness in Lahore. A condition when someone is deprived of a place to live and it is caused by a number of factors which has serious implications on homeless people. So there are more than 1,085,000 homeless people in Lahore alone. People experiences homelessness are known to have complex health needs which are often compounded by poor access to health care. Many of the urban homeless people live in unhygienic conditions, have disconnected social lives, at times have been denied access to social and medical services, or not having valid identity documents. So this might be the main cause that they are lacking to coming towards the healthcare system. The evidence provides a clue to the endangered health of the homeless people in Lahore. So the hypothesis of study is there are no ocular problems in homeless population in Lahore. Aim of my study to find out the most commonest eye diseases in homeless population. These are the material and methods. Study design was cross-sectional, sample size, all age groups, male, females, kids, to 289 people were included. Inclusion criteria, all homeless individuals of all age groups, living at different places, whether on roadsides, shelter homes, and camps. Excluded members, those who were not willing to be examined, or those who are having some sort of severe trauma or injury, or with some severe sedative drugs. Dependent variable, commonest ocular disease and the severity of ocular diseases. Independent, location of homeless person, socioeconomic status, and personal ethnicity. Instruments used to take vision and different eye examination were pen torch, ophthalmoscope, and Snellen and E-chart. Ethical consideration, which is the most important part of this study. Consent was taken from people by maintaining their confidentiality. Face shields and shoe covers and gloves were used for examining people living on roadsides and camps. Also, the image taking policy was followed. That is very important. According to a study, the most high prevalent areas where the people are homeless are Data Darbar, Minar-e-Pakistan, Chaburji, Shahi Kila, and Bhatti Chowk. This problem of homelessness is accompanied by some other social issues like drug addiction, beggary, prostitution, theft, and it also reflects the increasing inflation rate and shortage of affordable houses. So this is how the people living in such unhygienic and poor conditions, and they are facing so many barriers in their mental and physical health care. So these are the different places. We gathered our data from shelter homes, Darul Aman, from roadsides, and people living under the bridges in Lahore in the most high prevalent areas. This is a picture. I attended a complete workshop on inclusive eye health in 2019 in University of Lahore. You can see me in the picture as well. So recommendations, these are the results of my study. The performer was like having all the information, basic information, and the clinical examination. So this was the performer, the outlook of performer. Out of 289 homeless people, 78% had corneal ulcers, 43% had visual impairment, moderate to severe type. 49% had cataract, 18% had blepharitis, 10% had squint, 67% had conjunctivitis, 5% had styes. 5 persons refused to be examined, and 7 were in sedative condition of drugs. So recommendations and the message from my studies: quarterly or annual screening in form of eye camps, provision of spectacles and low vision rehabilitation. This is the take-home message of the study. Economic success without accountability and social inclusion is not attainable and sustainable. Inclusion is not bringing people into what already exists. It is making a new space, a better space for everyone. So I think it's giving you a message to include all sorts of marginalized peoples, whether they are homeless, whether they are disabled, or whether they are transgenders or prostitutes. We as being health care professionals should provide our services to them as well. Thank you very much.
Thank you, Taiba. Thank you to all the speakers for such wonderful, informative presentations. With this, we'll end our Optometrist Symposium, but before that, I will request Dr. Shehzad Saeed and Professor Dr. Fawad Niazi to present the shields to speakers. Ms. Serish Shahid. Mutahir Shah. Mutahir Shah. Ms. Sabah Ghalib. Muhammad Iqbal Javed. Asadullah. Ikra Khalil. Maryam Sanaullah. Taiba Burhan. Who will present? And Aisha Zarnab. Thank you, everyone.
Yes, sir. A shield for the moderator, Aiza Imtisal Sati.
Thank you, sir.
Please.